recording is running. Excellent. So let me welcome you to another Xtratracks. Today, really interesting and challenging topic in the field of telemedicine, obviously. Let's focus AI safety, presented by Elizabeth Boryck. Hopefully I'm saying it nearly correct. Again, University of Victoria, so we are again in Canada, the third presenter of Canada. And the stage is yours, Elizabeth.
Thank you, Sebastian. Very nice. I just wanted to thank everybody for coming out for the presentation. And I wish you, I think it's afternoon there and it's early morning here. So it's wonderful to be able to see everybody out. I'm going to talk a little bit today about AI safety, but I'm going to put it in context of some of the research that's already been taking place for many years around just technology safety, because I don't see AI safety in the same way as being so substantially different from other technologies that we've deployed in the healthcare setting. So we'll talk a little bit about sort of the growth of that research and some of the work that we're actually doing here around AI safety at the School of Health Information Science. So this is actually the campus. I thought I'd just show you where I live. That little red dot right down here is the actual Faculty of Health now. And I'm in the School of Health Information Science. And if anybody is ever visiting in the area, please do drop by and say hello. We can show you our labs, as well as some of our new technologies that we're working on in terms of creating robots and whatnot for the clinical setting. So today what I'm going to do is just review the evolution of the field of technology safety, discuss some of the issues and considerations associated with AI and health technology risk management, as well as review some of the methods used to assess and ensure AI safety and how we can actually improve AI from a learning health systems approach. I certainly don't think of AI as something where, you know, either we have it or we don't. We have to look at it as a technology that has been deployed, has been in use in many healthcare settings for many years now. We've have some new types of AI, so some of the large language models, and we have to start thinking of this technology as another tool that we have. And as many tools are out there, we have to refine the tool and improve the tool over time to make it more suitable for what kinds of technology we work with in a clinical setting, and for our clinicians specifically to feel comfortable with it and feel that it supports their work. So one of the things that I like to think of AI in terms of is a learning health systems approach. And to start off with, I want to define learning health systems as a modern evidence-based quality mechanisms to create safe, high-quality systems of digital healthcare, of which AI is a part of. When we think about learning health systems involve the use of healthcare practices in which we have health informatics, care culture, and we have the natural care experience seamlessly refined and integrated together in the context of continuous improvement and best practices. So when do we really start to embark on this issue around safety? I like to hearken it back to the early 2000s, when the Institute of Medicine actually developed a report called To Err is Human. And one of the things that they identified is that there were a lot of medical errors that take place in the healthcare system. So one of the solutions that To Err is Human actually recommended from a report perspective is that what we do is we start to implement health information systems in essence to reduce error rates. And they actually recommended some systems such as physician order entry, or what we call now e-prescribing, or clinician order entry. So with that report, we started to see a huge change take place internationally. And actually what we saw was that a lot of countries started to adopt electronic health records and other types of technologies to put in the healthcare setting. So we started to see the emergence of a technology-enabled healthcare environment. So as a result of that work, we started to see more and more technologies being deployed in hospitals and physician offices and other settings. And in 2005, which was roughly about 5 years later, we found out that we started to see the emergence of research in and around how health information systems could actually reduce medical errors, but also at the same time introduce ones. So what we found was that technology could actually have a role in actually being the origin of a particular type of error, which is a technology-induced error. So these are some of the early publications. We actually were involved in some of the first ones. And what we actually showed here at the School of Health Information Science with my colleague, Andre Kushnerek, that you can actually see that there was a relationship between the actual design of the technology and errors. So now we could actually start to say, well, maybe we need to look at the designs that we have out there and actually improve on them so we can reduce the probability that that design might influence the creation of an error. So since then, we have actually developed out a broader definition for this particular type of event. We call it technology-induced errors. And technology-induced errors are errors that arise from the design and development of a technology, its implementation and customization, any interactions that occur between the operation of the technology and the new work processes that arise from a technology's use, its maintenance, as well as the interfacing of more than one technology. So for example, you might have an IV pump that interfaces with an electronic record, and suddenly you have a linkage between the two. And if that interface isn't well supported or some error occurs in that process, we know that the error arises from the technology. So here are some examples of what I call technology-induced errors. So the first one is you have incomplete patient information. That's in the record, and you might have the wrong medication being given. You may have a poor display that's very difficult to read and isn't usable, and you might end up having a wrong medication given or the wrong strength of medication given. So there's a lot of different types of things that may actually occur from a technology perspective that influences clinicians' work and also may actually affect how they do their work and lead to an error. And again, it's located within the technology. So where do these technology-induced errors come from? They come from varying sources. So I like to think of it in terms of if you are an individual down here on the right side of the page, where you actually have an error occur, 90% of the time, the reason for the error is actually systems related. It isn't located with the individual. So for example, if you were using an electronic health record and that record has government policy embedded in it, and that government policy changes and that record isn't updated to reflect that new policy, then you might have an error. If you have a model organization where the technology, for example, is developed, designed, and tested, and you move that technology, such as AI, to another organization where there's a different data set, different culture, different approach to care, you could introduce an error. If you have a vendor organization that doesn't adequately gather the requirements from that organization when they're building out that AI, then what happens is that you could have a situation where that AI, when implemented, behaves differently in your setting, so you could introduce errors. You could also have issues if, for example, you didn't do adequate checking of workflow, interface design, policies and procedures, and local terminologies from a technology implementation perspective. And then what happens is once the technology is implemented, then it may cause conflicts in the workplace in terms of the workflow, then you could introduce errors. And of course, then there's the 10% time where an individual could have an error. But very much so, think of technology as having a systems-based impact on the individual that could affect what they do. And we all know this to be the case. So in 2012, so we saw a report that came out that said, please adopt technology in the early 2000s. By 2005, we had research literature that emerged that said technology could actually introduce errors that were unique to it and that were separate from necessarily what is happening. Then we had in 2012, again, the Institute of Medicine actually came out and said, we have to start thinking about health IT and patient safety. And one of the things that they actually said was to achieve better healthcare, proactive steps must be taken to ensure health information technology is developed and implemented with safety as a primary focus. And that actually, I think, forms the basis for many of the things that we do with AI today. So one of the things that I like to look at is evaluating technology in order to see if we can make it safer. And AI, like other healthcare technologies, needs to be evaluated. So when you look at evaluation frameworks, they generally come from three different literatures in the health informatics world. One is the human factors area, where we look at human-computer interaction. We look at how the technology is designed and influences human behavior. There's also the software engineering literature that looks at software testing, understanding how the software has effects on different components and interactions. And of course, there's also the organizational behavior and change management literature, which looks at how, when you deploy a technology in a given organizational context, what are the interaction effects between organizational processes, individuals, and the technology itself? And how do we actually modify those organizational processes and the technologies to have a better fit, to create a context for work? And so there's quite a few different types of frameworks and models that are used. These are just a few. This is a paper that I wrote a few years ago, but it's quite interesting because when you look at the different models and frameworks, you start to understand that A, you have these different influences, and B, is that a lot of these frameworks actually are very important to consider because you need to use something to reason out where exactly the particular issue is happening. So for example, you have an issue between a newly deployed system, and you might have an issue between the workflow processes that are present in that particular clinic. So again, very important. So from that perspective, it's really important to understand that the costs of making changes to a system after it has been implemented are much higher than they would be if you were testing and evaluating a system before it's deployed. So when you think of systems deployment, I think it's really important to remember the ideal situation is actually to evaluate that technology before that system is implemented. So you have a chance to make modifications to it before it's implemented and starts to change the work environment, has all the additional work that's associated with training people for using that technology, and then also is involved in the process of care. So from an implementation perspective, ideally you should be looking at the technology before it's implemented or after it's been implemented. And then of course, in cases where an error has occurred, then you have to conduct an investigation to understand where that problem started from and to actually fix it and find ways of remediating it. So when you look at this continuum, we have on the left side, prevention. On the right side, we have learning from errors. Again, a very learning health systems approach to doing that. Now down below are different types of methodologies that can be used. So for example, you can use evidence-based heuristics to look at technologies to identify if they have safety features. You can use clinical simulations to simulate real-world environments so that you can test out how well that technology works under duress. You can look at using computer-based simulations and usability. We're going to talk a little bit about each of these different types of approaches. And again, I'm looking at it more so from a prevention perspective. That said, you can also do different types of evaluations after a technology has been deployed, such as ethnographic approaches to study clinicians working with the technology and identifying where potential issues may occur. You can also look at, after an error has occurred, what kinds of things are happening to identify the root causes and analyze those incidents to make changes to the technology, policy, procedure, and training for health professionals in order for them to be able to adjust for the new change in the work environment. So a good example are evidence-based heuristics. I like to use evidence-based heuristics to look at the design and development of software through the procurement process, as well as in terms of evaluating software and optimizing for safety. And what this involves is actually using heuristics to step through a user interface, to step through a technology to see whether or not it has the features and functions that reflect what we know from the literature are important from a safety perspective. And these particular heuristics actually are used here in our province to look at systems from a procurement perspective and to understand what kinds of potential issues that could arise. Usability is also important. So here we have an individual who is working with an electronic record. and they're using a particular user interface. There may be AI that's embedded in that user interface. And it's really important because what it can do is it can identify specific aspects of the technology that influence the person's work with that technology that may influence safety. And that's really important because you can do this type of testing before a system is implemented with clinicians, and you can identify what types of user interface features and functions, including the technologies that abut them, such as AI, that influence or cause potential safety issues. And for example, in this particular case, there were some issues with display visibility. And as a result, we identified that issue and made some changes to the user interface. So in an extension of that work, because we know that clinicians not only work with individual workstations or individual technologies, we also know that they may be working with multiple different technologies. So here's a paper that we wrote a few years ago where we showed that it's really important to actually take different technologies that are new to the healthcare setting and to put them in an environment that's reflective of the real world. So these are simulated settings, and to test the technology out to see how well it performs in that context. So here's an example of three different areas. One is in an emergency department, another one is on a unit, and the last one is in an OR where we're testing out an operating room system. And then you can take that data and you can input that into computer-based simulations and project out what the impacts are of specific features and functions that may be an issue out over time and across large groups of people. So many clinicians working with that system. And this is an important methodology from the perspective that when you buy a technology, you might be sitting there and thinking to yourself, we bought something, there is a safety issue, there will be safety issues that you will encounter. And you may want to look at what the potential issues are and how you might mitigate them. And going through the process of actually looking at computer-based simulations with your IT team is really important, because then you can start looking at mitigation strategies. So perhaps changing the user interface design, looking at the workflow and enhancing it, looking at also the technology itself and fine-tuning it. And this might be something that you might do over time. You might also look at doing those evaluations on a continuous basis to see how things are affecting the work environment and refining how it's been implemented in order to make the clinicians feel safe and to also ensure that the technology safely performs. And here's an example where we actually looked at from a simulation output. In the blue line, we left the issue uncorrected. In the red line, it was corrected. And you can start to see that there's a reduction in the number of error rates. In addition to this, we've also developed safety checklists that can be used to configure software in large environments where, for example, in this case, this is actually a configuration checklist that was developed for the province of Alberta to look at the safety of an electronic medical health record system that they were deploying province-wide. And it really helped to understand what types of issues could potentially be a problem. And then on top of it, what it did is it allowed people to have a common view of what types of things you might need to consider from a safety perspective. And some of this actually involves decision support systems, of which AI is a type of decision support system for clinicians. Other things that you can do too in terms of a learning health system is you can collect data about incidents, and I think it's really important. It's also really important to be able to follow up with the reporter so that you can understand what exactly happened with the technology and what it affected and how it affected work, so you can identify the contributing factors and again, use that as a way of feeding back into improving the technology itself. And we know that incident reports can be a really great resource of information. In the last couple of years, they've been doing some research with the MOD FDA database, and it's really quite interesting in that we've been able to pull data from that database, and we have actually looked at different types of errors that have occurred. Now, one of the things that I sometimes run into, sometimes vendors will say, well, you know, errors occur and that's a natural thing. But I think it's really important to understand that the errors that occurred in the early 2000s, 2005, Those days are gone. We have errors that are occurring now where there are multiple different factors that are involved. So it's quite common to see an error occur with at least five different factors that contributed to that error. So the complexity of those errors is actually increasing. And that comes from the fact that we have multiple different types of software that's involved. So for example, you might have some incomplete clinical information that affected how the software that you're using worked. And that may have originated partially in the database because the database wasn't configured accurately. That might have affected the alerting system and also the workflow. So we're starting to see how multiple different technologies, when layered and interfaced together, could actually lead to particular issues occurring. And we need to start understanding what these types of issues are and learning from them from a healthcare perspective and also from a public and private sector perspective. So vendors as well as healthcare organizations that provide care. And we also know too that it's really important to remember that these types of issues are not necessarily unique to one particular vendor. In fact, after looking at some of the mod data, one of the things I found was that it's interesting to see that most of these issues are common across vendors. So for example, in this particular case, we have a system where we have interoperability issues, we have database issues, alerting issues, and social technical issues or social workflow issues, but we have two separate vendors and yet they have these common issues. So there's a lot to be learned from even different types of vendor systems. So you may think you have unique features and functions, but you're in between different vendors, but some of the safety issues are very common, and that's an opportunity to learn from that. So really important to take this type of data and actually use it to learn from what kinds of things we have as issues and to optimize systems and look at how we can make things better, and also to talk about this because it's really, really important that we learn from each other, because we may have things that are solutions that have been created by one organization that could be used in another. So when you think about AI, I like to think about AI as a sort of visions, right? So we have different visions of what AI is and how it'll actually be embedded in an organization. And then we need to understand what we're going to be doing to understand it from a safety perspective. So obviously, we do need methodological approaches that look at things such as user requirements, user tasks, activities. We need to consider organizational requirements prior to implementing an AI system. We have to consider the work processes and context. Where do we embed it? How do we embed it? Where are settings that we may want to try it out first before we go to more critical settings, such as, for example, in critical care or the emergency department. And we have to look at regulatory requirements from a country perspective and international perspective. So for that safe integration to occur. And so what we've been doing here is we've been looking at technology at that individual level. So as I mentioned earlier, we look at the usability of the technology with an individual user to understand some of the issues that are occurring. And that what we do is we see how that technology affects multiple users. So for example, a group of clinicians and what impacts it has. And then we extend that beyond to see how that technology may have cascading effects for other parts of the organization. For example, performance metrics, or looking at decision support systems for administration. So understanding at the individual level what types of issues occur, optimizing and correcting, moving up to looking at individuals and groups using the technology, optimizing and correcting, and then moving up to the systems or organizational perspective. So in that process, what we do in our labs is we actually try out different types of technologies. So for example here, this is a hospital room that we have designed in our school, where we're actually looking at different types of systems and how they might affect team performance when taking care of patients. And we've also included patients in that process so that we can see what the dynamics are of introducing, let's say, a new AI system or a decision support system in supporting care. What we've done is created a mock office where we have physicians and we have patients working with electronic health records with embedded AI, so we can see how that actually affects communication processes and interactions around work. In addition to that, we're also seeing AI moving into the home. So we have a smart home environment where we've set it up in such a way that it's the smart home environment of the future, where we have different technologies that may provide remote monitoring. And we test out to see what kinds of things happen in these particular settings in terms of impacting the individual, as well as their communication with a health professional. So you can see in this particular case, we have 2 students and we have a professor who is teaching, and we also have on the other side a connection to a virtual lab in another setting where we have health professionals. So really important. So where do you put these technologies? And we're starting to see that this is a really important area. I just recently was involved in some research with a large group of people in our regional health authorities where we were looking at hospital at home and also some of the technologies that could be used in that environment to support people that are that go to the emergency department, but then are in essence not admitted, but they're admitted to the hospital and monitored, but they are actually monitored at home. This also helps with things, for example, like selecting out different types of devices. In some cases, using devices the citizen already has in their home because they're comfortable with them, that provide supports. And it's also part of telehealth and telemedicine, because what it does is it enables a shift where you can have remote monitoring, you can have physical visits, and you can also have communication that takes place digitally that actually is somewhere in between, to make sure that that person is safe at home and that their condition is being monitored while they recuperate. And in addition to that, we have to start looking at different types of AI and how we can actually, when gathering that data, present it. So this is some work that we're doing in our lab environment, where we're looking at how AI may be used to support work during a public health emergency or even for disaster management. And this is one of our projects that we actually did with a group in the United States at the State University of New York, where we actually looked at what happened during COVID. And we decided we were going to model out from the interviews the types of technologies that were used, and also some of the issues around being able to access different types of technologies. And I think what's really interesting, if you look at this, so for example, outbreak surveillance, some of that could be automated. COVID subsystem looking at what kinds of issues are associated with COVID, and then updating the teams that are responsible for making decisions about hospital policy could be automated. Tracking individuals who might have been exposed can be automated in the context of scheduling systems. And also, we can also develop outbreak management systems that can be automated. And what I'm going to point out to you that's really important in every single one of these cases is, prior to the launch of more of these more current AI technologies, and during COVID, we had a lot of clinicians that were trying to work with very difficult situations, and they had to go to a lot of different types of information to be able to coherently integrate it and be able to provide guidance for all of the clinicians that are working on the units. So we're talking about infectious disease specialists, we're talking about chief executive officers. If we have systems in place that automate some of this work, it reduces the cognitive load for these individuals that are making these decisions about policies and procedures and treatment. And rather than having them go and look for this information in order to integrate it and be able to use it in a useful matter in responding to a pandemic, what we're doing is we're automating these particular processes to make it easier for them to be able to concentrate on the important things, such as making sure that they can actually deal with the pandemic, rather than worrying about trying to find information in different silos that is digitally located. So, so far today, our lab has developed quite a lot of different methodologies. If you're interested in learning more about them, this is a paper that I published, and it also has references to a number of these methods. What I want you to take away from all of this is that you need to take a layered approach towards identifying issues with any new technology that's implemented. Back in 2005, we were looking at electronic records, and we looked at mobile devices. Now we're looking at AI technologies. The important thing to remember is that you can afford yourself increased safety by doing some of this testing before the technology is implemented, and addressing those particular issues through optimization and addressing them through fixes. After it's been implemented, you can also do the same type of thing, and you can use these different types of methods across that continuum of implementation. So, for example, you could do usability testing before the system's been implemented, and then afterwards to see how people are using it. You could also do interviews after a system's been implemented, and periodically trigger these interviews to see how well it's performing, because we have to learn from our clinicians how the technology affects their work and how it impacts it. And really, if we believe in learning health systems, it's really important to understand that we have digital infrastructure, and AI is just one piece of that digital infrastructure. I like to think of it as a bricks and mortar hospital where each brick has a technology, and one of the technologies that now we're starting to add is AI. So it's important to make sure that brick is structurally sound and that we put it in a place that enables the building to stand up and really well to different types of conditions. And over time, what will happen is things will change. You may have changes in patient population, so you have to review the technology, identify what kinds of data sets it was trained on, refine it, configure it, change the organizational processes associated with its use. And that will actually change organizational outcomes. It may lead to more changes from a digital infrastructure perspective. And then we go through this cycle in a continuous way, and we make sure that our technologies effectively and safely support our clinicians and patients in the process of care. So again, I kind of think of it as terms of, we like to sort of catastrophize and say, okay, we have unsafe health information systems. I like to think of us in terms of we have safe systems that afford us significant improvements in safety. But over time, what we have to do is we have to keep pushing that orange button over to the safe health information system side, so we can actually create an ideal state. I mean, if we look at the aviation industry, we still have airplane crashes, but the number of airplane crashes is significantly reduced for the number of flights that we take in this day and age. And the reason why this is effective is because we do a lot of simulation testing before an aircraft is built, during the process of building it, and then after it's implemented, we have in-depth accident investigation. And I look at healthcare in the same way. We need to understand how our technologies support clinicians. And when there's an issue, we need to understand what happens so we can make that technology better so that it's safer and better over time. And if you look at it, we're kind of moving through different types of stages. I like to think of things in terms of maturity models. So, I have a maturity model for electronic health record implementation, but you can also have safety maturity models. You can start off initially with something that's more ad hoc. Then, and that's the case. When you introduce a new technology, you're trying to figure out what from the existing battery of evaluation tools you have work for that technology to understand it and see how safe it is in a given environment. Then what we do is we introduce these technologies, and then we do repeatable measurements. We define what we want to do from an organizational perspective, and we do that on an ongoing basis. And that what we do is we manage that technology and we continuously optimize it. And some of this work is done in an IT department, and some of this work could be done with a quality improvement department as a natural process. And these organizational units exist, and they have already started doing some of this work, but we have to formalize it. And we also have to let our healthcare professionals know that this is happening. So one of the things that I found that was kind of interesting is in 2015, and that was a little while ago, but I think it still applies today. There was a nice report that was written by the National Academies of Sciences. And one thing that they identified was that health system complexity has increased with the introduction of health IT. And I look at, in those layers that I showed earlier of the different pieces of cheese in the Swiss cheese model, where we looked at different types of technologies that were involved in an error, that AI has been added in as another slice. We know that technology is affecting the diagnosis and decision-making for health professionals, and this is nothing new. We've known this ever since we've developed decision support systems and even implemented our first electronic records. So we also know that those technologies, like the ones that are being introduced today, can affect safety. And so what we need to do is we need to start looking at how these errors occur and how we can fix them and prevent them from occurring beforehand. But the important thing to remember is to always go back to your clinicians, because that's the important thing, is they understand what they were doing at that time, when interactions take place, and they can provide significant insights in addition to things like, for example, logs from a systems perspective that will give you greater insights into how you can optimize and reduce or mitigate issues. So again, I like to think that to err is human. Systems are built by humans, and we have to learn and improve in order to make things better. So on that note, that's my thought. This is my contact information. I have a lab that you can see some of our projects. It's actually down at the bottom with the URL. Please reach out. My email address is there. And I'm also on LinkedIn. So from that perspective, it'll be great to connect.
Thank you for the excellent presentation, Elizabeth. We're open for discussion round. So in case you have a question, just unmute your microphone and enter the discussion. You can even ask on German. I could translate, or you could write it to the chat. Juliana, do you want to start?
Oh, sorry. The unmuting was unintentionally.
Okay.
I do not have any questions from a statistical side, so I appreciate the talk and all the information, but I cannot ask any questions.
So maybe then I would go for the opening question. So we had this year's Xtratracks at some places, the speakers discussing the corresponding medical device regulation laws in European Union, and the challenge involving the AI approaches, you typically want to develop a model and then you enhance your data set and you could retrain the model, and but that then would require recertification and considering the safety aspects, and you discussed it towards the later slides. That might even lead to the necessity to have a continuous assessment, right? Because so far, in my perspective, we are rather, from the legal perspective, focusing on certifying it once and then set and forget it, maybe checking the integration, but looking to worthwhile AI model-based system approach. What do you think about that?
Well, I kind of look at it in terms of sort of embedded. So you might actually have a AI that does a particular task and you're certifying it. But I still think that beyond that, that training that takes place and the actual process of certification, I still think you need to deploy it in a real world clinical setting and evaluate how it works. We need to really understand how clinicians are perceiving it. We need to understand how clinicians are adjusting for cases where the AI system doesn't actually provide an output that's meaningful or useful. And we also need to understand how it affects their workflow and processes, because it adds an additional thing to their work. And then with that, we need some refinement. So beyond just the actual AI model, we have to look at its performance in real world contexts. So, again, usability testing, workflow testing, simulation testing. You can even do modeling to see, projecting out how that technology will have an impact over time. And, in the end, if you're doing this as part of a procurement process, it may be that might be the thing that actually determines which AI model you use. It's the clinicians.
And then that might change over time because you're exchanging the large language model beneath everything, or some kind of the documentation being considered by the model would change, and unintended maybe, or the practitioners might have new learning surgery style involved, something like that, right? Another IT component would switch and alter approach.
And the clinician should be aware of the changes, right? Especially if they're significant and they may impact a decision, right? So some of the things that we've had here is that it might actually impact whether or not a person receives a particular intervention. And you need to understand whether or not the model actually did the appropriate thing, and if the clinician understood that it is able to critique it while it's being used.
So interpretability, explainability becoming a huge or a highly relevant aspect.
Yeah.
Yeah, thanks a lot. Any other questions? I'm just listening to the crowd. Yeah, there's the Russ. Just activate your microphone.
Yeah. Good evening. My name is Amit Kunati, from the University Hospital Eppendorf. I have thanks a lot for the wonderful overview. It's a very sensitive issue indeed, artificial intelligence, and it is good to have in the medical field, especially where all the sectors are very sensitive, especially oncology and ophthalmology and the transplantation medicine. But my question is a very general one. How do you tackle the problem of risk management with artificial intelligence concerning the models?
Yeah, so again, I look at it more from the perspective of as being, we're planning on implementing this model. So it's worth your while to spend some time actually creating specific types of use cases. And in addition to that, actually using the model in a simulated environment. So with clinicians on an artificial case that's representative, something that's not representative, and seeing how it actually impacts their work and their decision-making processes. My colleague who probably spoke with you last week, he does work on medical decision-making. So you can actually see how a decision support system affects a decision, and then understand if the decision was augmented or if it actually detracted from it. So again, we like to think about the technology by itself, but I like to think about it as the technology being used in a given setting. And then on top of it, adding in other features like, it's an urgent care situation. You don't have all the information. The model's trying to support your work, and you don't have time because you have to make a medical decision. And so we need to create those kinds of situations in a simulated setting and to test them out, and then get into a conversation with the clinicians who will be using it so they understand it and they can work through these issues before we implement. Because after we implement, there's a lot of things, it's a lot more difficult to pull something out and to retrain people than to figure it out at the beginning and send it in as fast as possible.
And are you using some software there are different softwares for the risk management, but are you using a particular software which you can just, tell us, or which you would suggest, could be beneficial,
So I don't really necessarily say that there's one particular software that you use. So, there may be different types depending on the situation, but I like to think of it in terms of methods. So you may want to do usability testing. You may want to do clinical simulation testing. Again, what you want to see is the interaction of the clinician with the technology and to see what impacts it has on their work. And even if, let's say, the AI model is just in the process of, it's trained, but it's not ideal, I think it's important to actually see how it performs and how a clinician reacts to that model. And then you can start to see what impacts it has. It may be that the clinician thinks that it is perfect and that it isn't. And that's an important discussion to have, because then you can learn from the clinicians why they thought it was that way. Or it might have the other extreme where they just don't feel comfortable with working with it. They see all the issues. So again, I'm into this idea that you have to disclose how the technology works and also problem solve around how it's implemented in that particular setting? That's an excellent question, though.
Yeah, thank you so much. Yeah.
Excellent.
And I must say you have wonderful publications, and it would be nice to go through the publications too, which you have cited in your presentation. Thanks a lot. Good luck.
Oh, you're welcome. And I'd love to collaborate. So it would be great to connect.
Thanks a lot. Bye.
I have to agree, Amit, regarding the publications. So there's one question in the chat. It's determining the explainability aspects of AI, considering would you rather take a very accurate model which has no interpretability or explainability involved, or would you prefer using the explainable model even though it's less sensitive, for example? How would you balance these?
I think some of this involves speaking with clinicians and actually determining what tolerance they have for ambiguity. And then at what point does this ambiguity affect their decision making and they decide to turn off the model and say, okay, I'm going to make a clinical decision. And it may be also that we might want to look at where the AI fits in the clinical process of decision making. So, for example, one could make a decision, make a diagnosis, and then have the model run and see how well it performs. Or we could use other types of ways of actually validating how well the model performs. So you can actually address this issue of tolerance around explainability. So, for example, a model predicts that someone has breast cancer. We do a biopsy. Yes, it's confirmed. And if the model isn't necessarily that explainable, we can ask our clinicians, if it does this in 99.9% of the time, are you comfortable with using it? And find out whether or not they would trust it. And that would be something that we need to start doing more of. And again, you could do this, you're in the procurement process, right? And you're deciding on which model you're going to pick. You can actually do some testing with clinicians and ask these questions, and that might actually influence your use. Because what you don't want to do is purchase something that you're going to just put on a shelf and nobody's going to use because they don't trust it.
Or don't have the time, right? So
Yeah,
that might be another aspect. Have you in your clinical simulation environment, have you considered the aspect how many of the practitioners are using the explainability functionality of such models?
Yeah, I have a tendency to look more so at workflow because I want to see what impacts it has. I think workflow has a big impact, and if it creates more work, then it causes more problems, and then a person doesn't use it. So and I think in some ways it's my preference, but I think that influences even explainability. I think explainability is important. I think it's something that also can be looked at, because in simulations you can actually ask these questions, right? Get the person to perform the task, you record it, and you can play it back for them and say, okay, well, we've noticed that you started behaving this way while you were using let's say the AI scribe. And did it affect your behavior? Did it affect your questions? Because it looked like it did. What was happening for you? And a lot of clinicians will be able to take you back to that moment and explain it. It's very similar to if you have an athlete that performs a particular, let's say it's a gymnast, does a backflip, and that's the performance that won a gold medal. So you can actually show that video clip, and that gymnast will be able to describe what was happening for them in that moment. And you can do the same thing with clinicians.
That's a good way. Yeah, that's a benefit of simulation. So I was thinking Jonathan might have a question, but maybe he muted himself already. Is there a question?
No, there's no question. Thanks a lot.
Okay, you're welcome. Any other questions in the group?
I have just a comment, Sully. Maybe I will. Yeah, my name is Sully Rita. I'm from the Universität Medical Center of Göttingen. And normally I am working in development of these explainable machine learning models too for the emergency medicine. And of course, we have for testing in some observational studies. We test with the medical doctors, the apps in the iPads and so on, and make videos to school the nurses and then doctors how to use the apps and so on. But what I have seen, in my particular opinion, is a problem that I see for the emergency department, especially, is that in such clinical or the lab environments, it is not the same. When this time, this pressure that the medical doctors really had in the emergency departments, it is not real, because the people know that this is a lab, this is a protected environment, and will nothing happen if nothing wrong, if there are bad decision or whatever. And my question is, how can we go around, or how this could be a best practice to jump this problem, or to manage this problem, in your expert opinion? Thank you.
So one of the things I find is that if you create realistic scenarios, and also ask people to perform specific types of activities that act as a stimulus. So for example, if you might want to create a scenario that is lacking in information, and that might actually lead to a person to, start the information seeking process. And that actually can be highly engaging. If it's realistic and it's difficult, then again, it will also stimulate an individual to actually engage with the technology. To me, I think that when you're studying individuals in a real world environment, so I'm talking about a naturalistic setting, let's say in an emergency department, it's a lot harder to kind of get at what exactly was happening at that point in time. Yes, there are those pressures. But there's also, of the fear of making an error, right? So the beauty of clinical environments is that's an accepted place to learn and also make errors. And if you create the stimulus materials with clinicians that are very realistic, I found in my experience is that they start to believe they're actually in the situation. They'll react to it in the way that they would have. And with recording what they're saying, as well as doing some cued recall, you can actually spend time eliciting what exactly happened and what was going on at that point in time, in order to be able to understand what was happening. So again, I would say, work with some clinicians to make the cases a little bit more difficult, a little bit more representative, and then see, again, you can create that. If it's realistic, it creates that pressure cooker feeling, because that person has experienced that in the past, and now they're experiencing it again in a simulated environment. It's not ideal, I will say that, but it's I think it's the next best thing to actually deploying something that you don't feel comfortable with doing because the clinicians aren't comfortable with it yet. Again, it gives them experience too with the actual technology before it goes in.
Thank you very much.
And as you have shown, Elizabeth, is just one step further to realistic deployment, right? Yeah. Excellent. In case there are no more questions, then let me thank you again, Elizabeth, for this great presentation. So, and we will meet next week again with Sylvia Thun, presenting her work in the telemedicine network, one of network university medicine topics.